Hi, everyone. It's 1:30, so we're going to go ahead and get started. I'm Dr. Susan Wolf, and my colleague Kyra Brown, Dr. Kyra Brown, is here with me from the University of Texas at Arlington. We're going to talk with you about sharing data with community coalitions to create an action plan and present a case story. Okay, let's start with our grounding. We'll begin with an acknowledgement of the legacy of obstetric racism. This is a term coined by Dr. Dana Ain Davis and operationalized by Dr. Karen Scott in the United States. This legacy predates the founding of the country and it continues in 2023. Positionality, I am a white cisgender woman, given birth to 2 children, but it was in the 70s, so it's been a while. A person who has benefited and continues to benefit from white privilege, a person who lives with a permanent hidden disability and a temporary mobility impairment. I'm the great-granddaughter of immigrants from Quebec, Canada, and the granddaughter of immigrants from Poland. I've been 37 years working as an evaluator, 21 of them working in this space. And
hello, everyone. My name is Kyra Brown, and I am a Black cisgender woman. And I am a person who has chosen to have children, but has not yet given birth to any children. Although my puppy would probably argue otherwise. I am a person who experiences undue light skin color privilege or colorism, the system of colorism, and a person who lives with a non-apparent disability. I am a GRIT, so girls raised in the South, so Southern US for those who are joining internationally. And I'm the second great-granddaughter of Amanda Howe, who was just an infant when her mother escaped the plantation to make her way down to the southern region of Arkansas. And I've been working 13 years in this space, both in academic and practice settings.
so a little bit of background about the project we're going to talk about. The Dallas Healthy Start Community Action Network, I'll begin by saying it's supported by funding from the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services, funding support from the state of Texas, Healthy Texas Mothers and Babies Initiative, and they receive their backbone support from Parkland Health and Hospital Services, the grantee, Dallas Healthy Start program. The information, content, and conclusions we're presenting are those of us, the authors, and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, the U.S. government, the Texas Department of State Health Services, Parkland Health and Hospital System, or Dallas Healthy Start. Okay, now the history. Dallas Healthy Start was established in 1994 with funding from the Health Resources Services Administration. It included a consortium at that time, and that served as a resource to the maternal and child health community. Later, it evolved to be a resource to support the program as the programming moved into case management services. In 2009, the consortium was changed to a collective impact model per the requirements of the grant. And in 2020, COVID forced the CAN into online meetings, and their in-person meetings have just resumed in 2023. So the CAN began by reviewing and discussing existing data, and there were very little data available. They reviewed March of Dimes Perry stats, which provided the breakdown of preterm births by race and ethnicity. They found some data from 2020 Healthy Texas Mothers and Babies and the Dallas County Health Needs Assessment. They also reviewed the state of Texas 2016 perinatal periods of risk results, which covered the entire state, though, not local. And they needed more information to use for planning. They needed to know more about what was going on with maternal infant health and particularly health disparities. So now I'm going to turn this over to my co-presenter, Dr. Kyra Brown.
Thank you, Susan. So next we're going to discuss perinatal periods of risk. Next slide, please. So before we engage in this discussion, it's important to emphasize that the perinatal periods of risk, or PPOR, is a very helpful tool, right? But one of the things we want you to keep in mind is that it was not originally developed within an anti-racist frame. And this is evident in the way that there's a heavy emphasis on maybe clinical determinants and interventions, and limited dialogue in general on acknowledging the inherent racist systems, both within and beyond the medical settings, that are the cause of excess deaths, which are captured within that framework. And so we suggest that the application of this framework also comes with an adoption of an anti-racist frame to situate your findings within a broader context rooted in racism and other systems of oppression. Next slide, please. So perinatal periods of risk, or PPOR, is an analytic and community approach for investigating fetal and infant death at the local level. PPOR was developed by individuals at CityMatch and Centers for Disease Control and Prevention between the timeframe of 2000 to 2004. And it was designed with the intent to identify opportunities to reduce infant death. PPOR was also a useful tool because it acknowledges some of the complexities of maternal health and infant mortality, and it helps to determine sociodemographic and clinical factors that may be contributing to excess infant mortality. So it's important to recognize that this is a framework that includes analysis, but it's limited to the data that are available most often through vital records. And so it's also important to recognize, it's important to recognize it's based on vital records, and that can be very limited. Next slide, please. Okay, so we're going to talk about the first step of the PPOR framework. Next slide, please. And at this step, it's important to ensure that, and this is community readiness, so it's important to ensure that effective community leadership and partnerships are in place, along with access to data of sufficient quality, sufficient staff and resources or partnership that's available to implement the data analysis that's a part of PPOR. And it's necessary to have sufficient community commitment for sustaining any change or plans for change that come about through this process. So starting off with stakeholder readiness. So as Susan mentioned in the overview of the history of the Community Action Network, or CAN, is that this CAN had been in place for quite a while, and coming off the heels of returning from virtual to in-person meetings and really trying to plan for action, they requested this data for planning. And so kind of getting to the readiness of the Community Action Network is that there was a lot of representation across community-based organizations and residents that were already a part of the CAN. And so between Susan and I, we're long-term collaborators, and Susan is actually the local evaluator who has been trained by CityMatch through the PPOR analyses and other analyses, and has experience with doing PPOR in other sites, other Healthy Start sites as well. And I myself, as a university collaborative, also completed a training with CityMatch, but having the capacity for some data security issues, which I'll talk about, and expertise needed to conduct the analysis, and leveraging kind of the university setting to do that. Next slide, please. So before we kind of get started in the process, this is also a part of readiness. And for some of you on the call who have maybe done PPOR already, you are probably familiar with some of the challenges. And we are in Texas, and Texas has a very detailed process for requesting data for at the county level or at the state level. And so we wanted to provide kind of a timeline, and I won't go through all the kind of time points, but there were a lot. But we initially made a data request to the state of Texas, which with that data request, you have to submit an IRB proposal with that, and you have to identify all of the variables that you need. So that was November 2019. And then of course, COVID happened, March 2020 happened, and everything was put on hold. And so I'll kind of fast forward through a bunch of kind of checking back and, updates and delays. And it wasn't until actually November 2022 that we actually received the data. So it took a while, which, that also required a lot of communication between Susan and I, but also with the CAN, kind of explaining what was happening in the background. Next slide, please. The second step of PPLR of the framework is focused on 2 phases of data analysis. Phase 1 helps us map deaths into 4 periods of risk for a reference population, typically those who have the best or achievable birth outcomes, and then what's referred to as the target populations in a community. Next slide. So we're going to talk a little bit about phase 1. Next slide, please. So phase 1 helps us map those deaths, as I mentioned, onto these 4 periods of risk, which include maternal health, prematurity, maternal care, maternal health prematurity refers to the period of risk for extremely low and very low birth weight. Maternal care is the period of risk for low and normal birth weight and includes fetal deaths. Newborn care is a period of risk for low and normal birth weight and includes neonatal deaths. And then infant health is the period of risk for low and normal birth weight and includes post-neonatal deaths. And so just keep in mind that PPLR is about action. The idea is that the identification of these risk factors or periods of risk is what drive the disparity between the target group and the reference group. It should also drive programs and interventions, which if you go to the next slide, we'll break down how these periods of risk according to the framework transfer to targeted interventions. So for example, if the high risk period is in maternal health or prematurity, typically those types of interventions will be targeting preconception health or maternal health behaviors or different social determinants of health. If the high risk period is maternal care, then that's going to be within that care setting. So focusing on obstetric care or high risk referrals. If the high risk period is newborn care, targeted interventions are going to include, but be not limited to, perinatal management or neonatal care. And then infant health, those interventions are going to be related to maybe safe sleep positioning or injury prevention. Next slide, please. So as a reminder, phase 1 helps us to map deaths onto these 4 periods of risk. And first, there's an initial step that involves data cleaning. So removing cases that are implausible, meaning they just couldn't possibly exist. And then removing cases that do not fit the criteria of PPLR. So for example, that's going to include births that are a gestational age that's less than 24 weeks. And, there is also the issue of missing data, and there's a need to apply certain imputation methods that are included in a lot of the reference papers that the developers of the framework provided. The next step, step 2, involves selecting a reference population. The general guidance is that the reference group should represent the group that has the best outcomes. And usually this is determined by looking at prior population data that's available. And in many cases, you will see a reference group, for example, being non-Hispanic white women or birthing people with, say, less than college education or high school education. And so there's actually a recent paper that was in Maternal and Child Health Journal, authored by William Sappenfield, who's one of the developers of PPLR, that focused on refreshing the reference group, since the framework was originally developed on data from 1995 to 2002. So for Dallas County, This was the case where we used non-Hispanic white women and birthing people with less than college education. And this was included as the reference group. And it's important to note that it's not because white women are considered the norm, but rather because of, again, that the anti-racist frame that we talked about before, is that because of systemic racism and the systemic privileges that it affords white women and how this manifests in better birth outcomes. So it's certainly okay to explore different reference groups. For example, you might consider different reference groups within certain racial ethnic groups. Next slide, please. So step 3 involves calculating infant mortality rates for the reference group and for each of the target groups that are the focus of your analysis. Next slide, please. So what we're showing on this slide is just showing how for each of the 4 periods of risk, you will have a infant mortality rate for each of those 4 categories, but that also includes for each of the target population. So in this case, non-Hispanic, Black, Hispanic, and all teens. Next slide, please. Step 4 involves determining excess or preventable deaths for each group. On this slide, I'm showing the data from our PPOR analysis, which shows that in Dallas County, 48% of infant deaths were preventable during the 2012 through 2019 period. We also found that 30% of infant deaths to non-Hispanic white women and birthing people were preventable, followed by 41% among Hispanic women and birthing people, 50% among teens, and 65% among non-Hispanic Black women and birthing people. Next slide, please. So next, I will speak briefly about phase 2 of the data analysis step, but we have not reached this step in our process just yet. But this phase helps us to identify factors that may contribute to excess deaths in the target population. And generally that includes identifying causal pathways, so examining the clinical causes of the death data, as well as estimating the prevalence of risk and protective factors by that mechanism, whether it's maybe these excess deaths are related to birth weight distribution. So the idea is, you need phase 1 to inform phase 2 so that you can proceed into action. Next slide, please. So the remaining 4 steps for this framework include developing strategic actions for prevention, strengthening existing or launching new initiatives, monitoring and evaluating these initiatives, and then sustaining the investment in these initiatives or interventions. And so Susan will now share the planned next steps as it relates to these steps in the framework.
Okay, the first thing we needed to do with once the phase 1 data were done is to share the data with the CAN. So we did it with a data party. Okay, a data party provides an opportunity for the community or the coalition members to come together and to learn about the data through dialogue rather than putting up a passive presentation and just having them sit and stare at it. It's done in a comfortable and collegial setting designed to continue relationships and community building while we get people talking about the data and just processing through it together. So here's some party tips. I know you probably didn't show up thinking you were actually going to get party tips today, but first thing, of course, is make sure your group is even interested. Do they want the passive presentation or do they want to get together and engage? I'll guarantee that almost every time they will want to do something where they don't have to sit through a PowerPoint. Decide what your theme is, get your logistics down, like where are we going to do this and what kind of food? Food is important. If you were going to have a party, I mean, you have to have food, right? So think about the food and think about, where you're going to order it from. In the case where maybe you're working with Black infant health and maternal health disparities, maybe it's a good idea to get some food from a Black-owned restaurant or catering service. Think about those kinds of details because they are important when you're trying to plan for events like this. Think about if you have community participants that are coming, are you going to pay them or offer some incentive? Remember, your professional people usually are showing up as part of their job. They're getting paid to be there. So it's always a good idea to think about for the people who are coming from the community, maybe they should be paid to be here too. And which data do you want to share and include? With PPOR phase 1, it's pretty easy. The data are self-evident. But you might want to have a data party and bring in some other data as well if they'll help shed light on your results. Is it voluntary? People should know that they're coming to this data party because it's voluntary. You shouldn't, you can't kind of force people to come to parties, right? And who's going to facilitate the party? Find a facilitator that will understand how to keep that party moving. It's kind of like this is your DJ. So when it comes time for the party, you want to summarize the sections, and we'll go over a little more how we did that. Be open to new meanings. When people start talking about the data, they may say things that you would never have thought of. Sometimes things just pop out and you'd be like, oh, I wouldn't have thought of that. Watch and have your facilitator watch. Are people staying involved, or are they spacing out, pulling out their phones, doing all this stuff? Or are they really participating? Discuss multiple meanings of the data. Sometimes there's more than one meaning to different people, or more than one reason. Make sure that when you're thinking about your data and working with any kind of data with a community group, make sure you're balancing data rigor, but not at the expense necessarily of relationships. Sometimes you can use a little bit less rigorous method of maybe they'll decide they want to collect more data qualitatively. Well, maybe you won't be as rigorous, but you'll get better information. You'll get something more in depth. And get feedback. Always, always have your group or your coalition give you feedback. Hey, how'd you like this? Was this a good way to get data? Do you have any ideas for how we could do it better? And there's ways to do that instead of asking or sending out the survey, right? We just did an event where we put up 2 sheets of paper on the wall that people on the way out, they filled out a sticky note, and 1 sheet of paper said, here's what I liked about today. And the other one said, here's what you could have done better. And then just had people write things out and slap them on their wall on their way out the door. And that was enough. That was enough feedback for us. We didn't have to go through a whole survey thing. So some possible questions you might ask. Remember, if you're sharing data with people, it helps to prompt them if you ask some questions. How does this make you think or feel? And what surprised you in these data? Or what confirmed what you already knew? And what was missing that you thought you wanted to see? Find out what more data people might need if they really want to understand more. What meanings do you see in the data? When you're sharing data with a community and it's about their community and you're not from that community especially, and that's not your community, you have to walk in with absolutely no assumptions and just let people talk and listen to what they say, because you probably just don't know what might be reasons for these results. Boy, people will come up with a lot of good ways that these things might be going on. Things going on in the healthcare system, in their neighborhoods, in their cities, that you just don't know about or you haven't heard of yet. And then what ideas do you have for action? This is your chance to start getting people to think about, hey, what kind of things might we want to change? And keep in mind, though, as you're asking these questions, you need to assume a trauma-informed approach, because this is keeping in mind that when you're dealing with birth data like this, there will be trauma involved for some of the people that are there. They're going to have responses that are uncomfortable. And so you have to be ready to step back, have some moments of silence. We held a moment of silence for reminding people that these were souls that are lost, not data points, but actual mothers who have experienced losses. So we had a moment of silence where people could pray or reflect or just regather themselves after dealing with this difficult time. So keep in mind that the data that you're dealing with are not just data. These are lives. These are people. So here's a copy of the front of a placemat we shared. So we shared the data by, we served food and all that, but everybody had a placemat, and this is what their placemat looked like. And what we did is we went through it a section at a time, talked about what is PPOR, what data did we use, what were the different groups. We talked a lot about what that internal reference group and why we used it and what that means. Then we pointed out all of the statistics. Of course, we shared, as you can see in the middle, there's this whole, here's all these numbers. We did not stand there and go through those. We just told them, yeah, all those statistics are in the middle section if you want to see all the raw numbers. But finally, we talked about the rates and pointed out the disparities, and then talked about where we explained what preventable deaths mean and looked at how many deaths could have been prevented. Because that's the bottom line, is these were lives that were lost. That if all things were equal, if there was really equity, they didn't have to be lost. So that represents your inequities. And then we shared this side of the placemat, explained what everything meant, pointed out the highest rates among Black women during the maternal health prematurity, infant health and maternal care, still higher than the rates of the other groups as well. So we went through and explained this as well. So were we just, again, this sounds like we were just talking data again, right? But here's what we did. We put questions on Post-its on flip chart paper on the wall, and we had electrostatic sticky notes. That's my favorite new facilitation toy. If you haven't seen electrostatic sticky notes, you got to look them up. But we had people write their responses to the questions on those sticky notes as we were going through the data. And that gave people, there's always the quiet ones or the introverts. I'm an introvert, so I know by the time I finish like processing and thinking through, 10 people have raised their hands and I'm not going to speak up anymore, right? So we had people write down, instead of speaking out and raising hands and all of that, everybody just wrote their answers so that they had a chance to reflect. Everybody in the room had a chance to contribute, to say what they needed to say. Some of them were saying the same thing maybe, but at least everybody's voice. And then after they wrote their answers down, they went up and stuck them on the wall on the appropriate page, wherever that question was. We also reminded them to keep thinking at that systems level. We explained what systems level meant, and we had them encourage them to keep thinking at that. Let's get away from the program level and start thinking about what needs to change at a higher level. Policies, where might there be advocacy needed? Where, maybe better coordination, but things up at the systems level. And then we read out some responses during the data party, and then we wrote all the responses up and shared them back. There are other ways to share data that are fun, and I'll mention them. One is data chocolates. You can get little Hershey Kisses or those little tiny, Halloween size or whatever candy bars. Put something about the data on each and wrap the paper around. As you'll see at the bottom of that Hershey's Kiss is a little bit of data. And then you have people, and I mean, who doesn't like getting chocolate, right? Just a few people, and that's okay if you don't. But the best part about it is everybody has a different fact at the table, and then they can sit and share their facts and talk about them. There are data walks that are also similar. You put graphs along the wall, and people go around in groups with their questions, and they talk and in small groups, and they rotate around the room looking at those data results. You can have members do things like develop elevator speeches, right? That little blurb about the findings that they can get out between the time they get on the elevator and whenever they hit the top floor of the building. Members designing infographics. It's really fun. Bring all the kindergarten art supplies you can find with these big sheets of butcher block paper and let people have fun designing infographics. Show them a few examples so they know what you're talking about, but they can also design them on paper, and then there's always somebody who's really good at actually putting them into Canva or something. And so then they can do their own messaging for dissemination, and then preparing success stories as well. But those are ways that you can share data with community members. And they're fun and they're engaging, and they have people working with the data and not just passively, doing, sitting and listening and falling asleep and getting on their phones. So what are our next steps? Okay, well, post-COVID, we found that we needed to lay some new groundwork and revisit that readiness. During COVID, we had good turnout, but online and everything. But when we started getting back in person, there had been, I mean, you know how it is in communities, right? There's always turnover in all the agencies and nonprofits, and people move to different counties. There's just, things got shuffled around. So after the phase 1 analyses, we wanted to do the strategic planning, but as the group began reconvening in person, they looked around the room and a few things became obvious. Community readiness had changed, and so it was time to revisit that and lay that new groundwork. So one thing they decided to do was redo the bylaws, because they had never been examined through an equity lens. And so more importantly, as the CAN continued its transformation to a community-owned action network, little by little, the project has been working more and more to hand this off, to have the community take more ownership of it. And the bylaws had not been written to accommodate and support that transformation. So the CAN has now revised the bylaws, shared them with the membership, and membership is now voting on whether to accept these changes. There are things like how the leadership, what constitutes membership, how the leadership is going to be selected and who's going to lead. And they've decided on things like co-leadership with a agency person and a community representative, so that there's always somebody from the community in that chairperson spot as well. So they're also deciding it was time to re-examine the membership. Who's still at the table? Because a couple people had turned over and were, in the process of being replaced, but they wanted to make sure that they had key representation from the informal sectors, things like your neighborhood associations, church groups, parent-teacher organizations, but also from the formal sectors, representing the major institutions, bringing in more of the healthcare institutions than had been at the table, making sure the government was well represented, businesses, local businesses, bringing them to the table, different educational institutions, engaging like some of the local universities and community colleges, because students are great to have. And this is the age, their demographic is at that age, that this is a good time to get them engaged in these kinds of issues. So the CAN is working on increasing the membership, making sure the membership is more representative. So next up, they have bylaws, revision and adoption, member recruitment, and then we'll complete the phase 2 analyses for more specific insights. Then the CAN will engage, when all that's finished, the CAN will engage in a strategic planning process to develop those action steps at the community and systems levels. And we'll be using the technology of participation, inclusive methodologies to ensure that, the plan includes all of the voices. So at this point, wow, we finished faster than we expected. We talked fast. Anyways, we'd love some questions and comments. I see a comment that it's creative and would love an info source on the party ideas. My favorite source is Kylie Hutchinson. She's an evaluator from Canada, and she did a great AEA through the American Evaluation Association 365 blog on data parties. And then if you Google data parties, a lot of these things come up. So, and data walks, the same thing. The American Evaluation Association is a great resource for a lot of these kind of participatory methods. Other questions, comments, put them in the chat. We'd love to have some dialogue about this and answer questions. Hey, love to connect to bring a data party to my community. Amazing work. Oh, we're always happy to come to your community and help you with it. Love all the pointers, hosting, facilitating. And we do have, but we're always happy to help with data parties and others. Our emails, here's our contact information if you'd like to get a hold of us and ask questions. We can send you resources. We'd love it. That's great. Yeah. Kyra says, as you're thinking of, has anybody done anything like this in your own work? And how do you share data? So you should be seeing our contact information. Do feel free to email us. I know sometimes I'll go to something and I'll think of a question like 4 days later. We don't mind email. We don't mind if you email. Just say, I heard you speak at the HRSA conference, just to remind us, because I always need reminders. Like I say, I've been at it 37 years, which kind of tells you a little bit about my age. So, you know, more reminders, better. How long do we hold the meetings for? It might be just a 2 hours. Most people after about 2 hours are starting to, you know, glaze over. It's a lot of numbers. So I wouldn't suggest doing one of these. You know, you might, if you've got enough, maybe you want to have a data party at one time and have a data walk the next time, thinking about how to share it. But I always would start with the party if you can get the food and just making it festive enough so that, you know, because remember, this is a group that you want to use these data. So you want to get them sitting and having some social time, some time to bond with one another, because eventually they're going to be working together. And if it's a group that's still getting acquainted or getting back together in person after a couple of years, give them a chance to sort of have food and, you know, just visit.
And I think because of that reason and that relationship building that you want to build into it, just knowing that it doesn't, you don't have to do just one, like you could make it a series of, maybe it's a series of 3 1-hour ones, or I think it just really depends on your group and the context. But it doesn't have to look like one single sort of format.
Oh, thank you.
I know, you know, we're asking for questions, but I'm also kind of interested in what brought people here today. And so we can kind of use this time too as a back and forth dialogue, but just seeing folks in the chat talking about kind of what they're doing or wanting to do with their groups, but why did you show up today, and how does that connect to maybe some ways that you want to use data with your community? And maybe there's other things that we can share based off of that.
We probably should have shared that we're both community psychologists. So we've been, a lot of our training, our time, our careers have been spent learning how to work with communities and coalitions and collaboratives to strengthen them, to help them form, to help them move toward action. Okay, Laura says, I have a new business in my community and I'm networking in my community. I'm a licensed clinical social worker. Okay, that's good.
Yeah.
I talked earlier about the trauma informed, and that can be very helpful when you're dealing with these topics. Oh, the SOARS operations manager for DHHS in Utah will soon be sharing data in regards to stillbirth. Okay. Yeah, definitely in that case too, make sure there's someone there that can maybe manage trauma or has an understanding and can recognize if somebody seems to be having a response.
Yeah.
I partnered with a colleague last week. We were doing some work and she brings ice packs, and I had never heard of that, to use as a response and have people put them on their chests or the back of their necks or their heads, and it helps people cool down. But she had these little breakable, you just snap them and they become ice packs. And that again she's a clinical social worker, so she understands. I'm not, so I don't. So I like working with people who do know.
There's another comment from Jenna, always looking for new and interesting ways to share data to be useful to our partners and the public. I've also started undertaking the PPR analysis, so I was very interested. Cool.
Oh. And Elizabeth says, considering how to create space for data sharing that also fosters relationship and trust building. Yeah.
Yeah.
Yeah, this is a great way. I mean, just any of these participatory methods and methods that have other people who are interpreting, talking. Oh, we're starting to get comments. Okay. Whitney says, I enjoyed this. It's useful for me to use our next community event. I'm a licensed mental health therapist who specializes in perinatal mental health. So we try to implement creative ways to discuss the data without it being redundant or the data leaving people feeling discouraged. Oh, yeah. Yeah. And that's where that question. Oh, go ahead, Kara.
I was gonna say, I'll add to that. So even with like the placemat, one of the things that I love about the placemat is that in a way it forces you to focus on the most important data, or at least the most, to force yourself to ask the question of what's most relevant for this group. And you can always have multiple placemats for different times, but it really helps you to avoid kind of data overload, right? So I think that's one of the things that I like about the placemats, make it digestible.
Yeah, that, and another way to keep that from feeling discouraged is you might want to follow up. There's a lot of more aspirational ways of planning and stuff, using techniques like appreciative inquiry, getting people to dream and vision, so that we don't just present this gloom doom sort of scenario, but we start having people. And that's why I always ask that question, what do you think are some actions we can take? Because you want people to start thinking we can do something, we are going to do something. And I think that lets them leave with a sense of purpose rather than, oh, that was depressing. It is depressing, but I just started a new position in North Carolina DPH, overseeing a strategic plan that just ended, looking for creative ways to assess the activities of the previous plan and how to build collective ownership for that next plan in a way that's really data driven. Yeah, we're, as I mentioned, we're going to use the technology of participation, strategic planning methods, and those are very participative. They're, you use the data and all of that, but they're also a way that everybody that participates owns that plan. You end a top strategic planning with a plan with timelines, with people who have volunteered and said, okay, this is what I'm going to do. I'm going to do it by this time. So I would suggest looking into that perhaps, and having somebody use those methods would be helpful. How do you control the energy who want to implement change right away? Oh. I think I usually just explain that I am so excited to see so much energy. I mean, and it is. I mean, when people want to get out there right now and remind them that we want to make sure we're doing the right thing and we want to make sure we set it up for success. So getting them to sort of slow down in a way that says, we love your idea, we're interested in doing this, and let's slow it down a little bit so we make sure we set up, like I talked about. If you're going to do things, you need to build in evaluation. Because remember, as you're trying to things in the community, you always want to be getting feedback that tells you, are there any unintended consequences? Is there any chance that maybe it's not working? Are there indicators that maybe it's a problem? And so say, you know, we want to set this up for success. So let's write this down. Let's keep it at the forefront and let's put it into our planning when we engage in the planning next month. So make sure that you have considered it. They know that you are seriously considering this and you want to make sure it succeeds. The top network. North Carolina, there's always training going on in Asheville. I know there's quite a lot of the trainings are held there. I work at a local public health agency and utilize data, knowledge, and experience from community partners and caregivers who have a child with special health care needs to help inform our strategies for future work. I like the different ways to share data. Have you used storytelling in your work? Oh, yes. Yeah. I like storytelling because I think it makes data real. Mm-hmm. Numbers are numbers, but until you put some stories behind it. In fact, anybody interested in storytelling, the American Evaluation Association's conference this year at the beginning of at the end or sometime in October. I think it's earlier October. They changed it this year, but that is going to be focused on telling stories. The whole theme of the conference is about telling your story. So if you're interested in learning more about that, I suggest eval.org and look at the conference. It'll be in Indianapolis in October. Technology of participation techniques, other publicly available resources online. Y'all are amazing people. Thank you. Clinical psychologists who want to improve mental health outcomes in my community by creating a coalition. Coalitions are great, that they can be so powerful. Yeah, I love working with coalitions. That's one of my favorite areas to work. And I know a lot of resources, so if you email me, I can send you some potential links to books and things like that. Thanks for putting that AEA
You're welcome.
address in there. I never seem to put things in the chat. But
And Lynn, I wasn't sure if we had any questions in the app, but I'm assuming that if we did, you would have.
Yeah, I have not any to pass along at this stage. Thank you, though.
Okay.
okay.
Well, I guess if there's no additional questions, we have our contact information here. You can scan our QR codes if you're able to and look us up. And as Susan mentioned, okay, one more question.
What are the types of actions you are considering taking to address PPOR?
So we haven't completed the second phase. The second phase is really about identifying some additional information to inform those actions. So we're halfway through the process regarding that. So it's hard to tell just yet.
Oh, that's good. Have y'all held a virtual party, and how does that change the dynamic? Well, as we all know, virtual just isn't the same as being in person.
Yeah.
However, it is very doable.
Mm-hmm.
I've done things like this using Google Jamboards.
Yes.
So you can still have people posting answers to questions, getting them all on Jamboards or Miro boards, if you use Miro. And of course, you can email ahead of time or just drop the placemat into the chat and share it that way. I'm getting to where I'm less and less enamored with PowerPoints just because people are we've been online since 2020, and I think we're all tired of staring at PowerPoints. And so anything you can do, again, using Jamboards, using breakout rooms to get people talking in small groups and working on things in small groups. Just think about ways to get people talking and doing the whole time without a lot of, you might show one slide. Okay, here's a fact. Now, here's some questions. Here's another fact. Here are the questions. You could do it that way. You can, have the Jamboards and go through one at a time with fact, and then have people just put their comments in there. I mean, just being creative, I think, is the most important thing, but keeping people engaged.
Yeah, I'm a big fan of Jamboard. I'm a big fan of sticky notes and flip charts. And so when I came across Jamboard, I was like, oh, yes. I was trying to find a way to, early on in the pandemic, really trying to find a way to replicate that. And, there is a level of planning that goes into that with kind of pre-planning your pages and, thinking out the process a little bit more in detail in terms of how you sequence those pages and, what information is going to go on this page, and then what page do you want for, the sticky notes, as well as, of course, making sure some technical assistance is available to the users. I've had various different scenarios where some people catch on to Jamboard quickly after a brief, instructional introduction, but some people kind of struggle. And so having someone on the side who can pull those people virtually to the side and kind of assist them with that as well. So those are some lessons learned that I've had.
Yeah. Oh, the types of actions taking to address PPOR. I'm not sure. That will have to be community generated. Whatever they decide to do here will be completely from the community. I basically serve as a facilitator in the process, and the data sharer, the facilitator, and the community are the ones that do they do the work, they do the thinking, they do the planning.
And as mentioned, they need phase 2 to do that.
Mm-hmm.
You're welcome, Laura.
To end the webinar, if you're good. That was wonderful. Thank you.
Thank you, Lynn.
Thanks.
All right. And we'll have the recording up within Hoover, and then we'll also have it on our website. Hoover will only be for 3 months.
Okay.
All right. Thank you. Thank you, everyone, for attending.
Thank you.